beginning its invasive process below the basement membrane, that we could do a cone biopsy, removing the cervix, and have a high likelihood of cure. It's a little different with glandular lesions. This is one of the areas where there is a change. What I've shown you here is a squamous lesion. Right at the top is the basement membrane. This is the stroma of underlying tissue. And what you see is a very small cancer that has invaded below the basement membrane. While with squamous cancers, you can see the basement membrane, you can measure with a micrometer on the microscope how deep that is. And so it's very predictable, it's very uniform of being able to say exactly how deep it is so that we know if she's at risk or not. With a glandular lesion, remember that the glands reside below the basement membrane of the surface epithelium all the time. That's where they live. And so if a cancer occurs there, an adenocarcinoma, it's very difficult biologically to assign a depth of invasion because you have no surrounding surface epithelium to serve as your reference point. And this means that with glandular cancers, historically, people have almost ignored the concept of microinvasion and gone straight to radical surgery. There is, though, new evidence, not big papers, but several different institutions publishing case series in the United States, that we could use a different approach for microinvasion that's glandular. Instead of measuring the depth of invasion, what we do is measure the spherical volume of the tumor. And as long as it's less than 100 microliters in diameter or in volume, then the likelihood of spread is equivalent to the microinvasive squamous lesion. And that means that we could, again, manage conservatively. Now, for those of you who are not pelvic surgeons, it's also worth talking a moment about what exactly is a radical hysterectomy. Why is it different? The term hysterectomy means to remove the uterus, but radical is a much different operation. So to orient you to these diagrams for the next few slides, our patient's head would be towards the ceiling. Her head would be towards the floor, her feet would be towards the ceiling. And what we're seeing here is the bladder and the uterus. And so I'll just kind of walk through the anatomy of what we do that's different and why it's important. So when we do a radical hysterectomy, we first open the peritoneum, we remove the lymph nodes. You've heard how important the lymph nodes are or how often they may be involved. If we remove the lymph nodes and they are free of disease, this is excellent prognostic information for our patient. She's much likely to do better. And so we remove the nodes to find that out. We then dissect the ureter on its path from the kidney towards the bladder, and we begin to dissect it out from the tissues. This will lead us to taking the ureter where it crosses under the uterine artery, which is the blood